Thank you for inviting me, chairs. I do not speak Chinese. There must be a problem with my presentation. Maybe you have to re-upload it. So thanks again. It's not only an honor to come here, but it's always coming back to friends. Thanks a lot.
Vice versa.
It's a little bit difficult now to come from lung cancer screening to sleep medicine again. Maybe it's fulfilling the loop from Esther's talk. Chinese. And also, it will also include the question of implementation within Europe. So there are some points to conclude. So the question is, how can we deal with non-CPAP therapies for obstructive sleep apnea? How are guidelines published in the ERJ being performed, be accepted in the population? What are limitations for the implementation? What are perspectives? So you know of all these pathophysiological concepts addressing more than one obstruction, more than one mechanical aspect, but also including the loop gain of breathing regulation, the arousals which influence breathing disturbances, and also the upper airways, the muscles of the upper airways, which have an influence on the obstruction. So having this concept in mind, we can try to address different of these components to treat patients, not only with CPAP, but also with alternatives. And that has been addressed in the guideline, in the non-CPAP therapy guideline. And let's start with some aspects focusing on the dilation of the upper airway mechanics. So, of course, one is the influence on body weight regarding surgery. So we start with the surgical part. So we know a lot about different bariatric surgeries. Here's one example showing that bariatric surgery actually reduces body weight. That's not surprising. And also improves sleep apnea. And therefore, the recommendation of the guideline was we can give a conditional recommendation for the intervention, here in this case, laparoscopic bariatric surgery. And after implementation of this guideline, we did a survey 1 or 2 years later. In Europe, different colleagues in our group, in the assembly, were so kind to give their information how it looks in their country. And here you can see that bariatric surgery is in many countries in Europe full reimbursed, available, so the implementation is good, and the cost is difficult to say, it's often unknown, but those who answered said it is between 1,000 and 8,000. But you can see this surgical approach is available all over Europe. What about ENT surgery? So the guidelines are very critical with ENT surgery. We say that there is a positive recommendation for tonsillectomy and also for destruction osteogenesis in specific malformations. However, there is actually a negative recommendation against nasal surgery, radiofrequency surgery of tonsils, uvulopalatal flap, and other surgical approaches. There may be a role in individual patients, not in general, for some other approaches. So you can see the European guideline on non-CPAP therapies, ENT surgery, was very critical and allowed it or recommended it only for very selective and individual cases. If you go to the map, you see, although it's not recommended or only mildly recommended, it's available in most countries. So a discrepancy between the scientific evidence on the one hand and the availability within the countries. Another approach, a very effective approach, is the maxillomandibular osteotomy. Of course, it's not fun for the patient, maybe for the surgeon. And what you can see is that the maxilla and the mandible are put into the forward position by 1 centimeter or so, and then this actually drives the tongue forward and opens the upper airways, and therefore is very effective, long-term effective treatment of obstructive sleep apnea. Therefore, we gave a conditional recommendation for either the intervention or the comparison, which was CPAP. So that means you can use mandibular advancement surgery in those patients who cannot tolerate CPAP, for example, and who want to have a definite solution. Availability, again, for this surgical approach, quite good, available all over Europe, not in all countries, but in many countries. What about other options regarding overweight? And we are discussing a lot about weight-reducing drugs. And here you see 2 studies focusing on this from Blackwell and from Malhotra, recently published in the New England Journal. And they all showed that there is a good effect of the weight-reducing drugs in terms of weight loss, also over the long term if taken for a long time. And this also influences sleep apnea. What about reimbursement and availability over Europe? It's very different. You see some countries have it good available and also reimbursed. Others have actually no availability and of course no reimbursement. So although these drugs will have a place in weight reduction, it's not available, and this had a lot to do with cost. What about mandibular advancement devices? There are many studies using mandibular advancement devices, and you can see that there is a good effect on mandibular advancement devices in terms of Epworth Sleepiness Scale, so sleepiness and quality of life. They are less effective in terms of AHI, and therefore the recommendation of the panel was, if you compare it to CPAP, we have to prefer CPAP as a recommendation. CPAP is more effective in terms of breathing disturbances, oxygenation, but on the other hand, it's equally effective in terms of sleepiness. And there are also benefits in terms of preference of the patient and therefore adherence. So therefore, we said in mild to moderate obstructive sleep apnea, the difference in terms of the AHI becomes less important. And because of the equal effects on quality of life parameters, both devices or both approaches can be considered equally in patients with mild to moderate sleep apnea. So we not only, in general, we have to say CPAP is to be preferred. On the other hand, if you go to patients with an AHI below 30, for example, you can use both devices equally. There's not only the challenge of availability regarding mandibular advancement devices, but also the question of patient selection. Do we have predictors of treatment success? And this is quite difficult. Often it is just trial and error. You build such a device and see if it works. But this is, in terms of cost, not very effective. So there are some attempts, for example, with test devices, but you can also do, for example, this radiographic evaluation. You can, now we are in Greece, brachy, meso, or dolichofacial shapes, and this can help you to decide if this patient has a good chance of response to mandibular advancement device. Here, in this situation, we have a good chance of response, while there is in the dolichofacial shape only a poor response. In terms of availability, again, we have a widespread difference over Europe. There are in the central of Europe, there are more countries who have full reimbursement for this. There are other countries where it's much more difficult or not available at all. And also the costs differ a lot. Here you can see that there is a spread between 300 and about 2,000 euros per year for this approach. And this is not very cheap. For example, in my country, the cost for a CPAP device with everything, with mask, with tube, with service from the manufacturer is about 200 euros per year. So it's actually cheaper than a mandibular advancement device. What about positional therapy? Well, there have been several trials over the years, vests, balls in the pajama, and we all know they do not work. They may work for one night, but not for the second. Patients do not use it over the long term. However, there are other approaches. For example, this sleep position trainer, which is a vibration alarm, which stimulates the patient whenever he wants to go to the supine position to change the body position to the lateral position. And over the time, if you use it every night, after 1 week, 2 weeks, 3 weeks, patients get used only to sleep on the lateral position. This has also side effects. You can get pain in your shoulder. However, it's an effective treatment, as has been shown in prospective RCTs. So therefore, we considered this approach also in the guideline, and we found that compared to CPAP, CPAP of course is more effective. However, if you compare it to other treatments, the difference is less. So compared to CPAP, we said for those patients with positional sleep apnea, so the selective group of patients who have only or mainly breathing disturbances in the back position, you can use both devices, positional therapy or CPAP. And this is also true if you when you compare it with mandibular advancement devices. So positional therapy has a good acceptance in the guideline, but it's not available in Europe, almost not available. So this option, which is a quite easy option, not expensive, but we have different difficulties to bring it to our patients. So what about the other aspect, stimulation of the upper airway muscles? And we can discuss about myofunctional therapy. This is a picture from a study published several years ago in the Blue Journal. This is how it may look like when you do these training sessions. You should do it every day, and you can imagine that this may not have the best compliance over the long term. So what are our recommendations based on the scientific evidence? If you compare myofunctional therapy against no treatment, there's no difference. So the recommendation is you can do either myofunctional therapy or nothing. If you compare it to CPAP, of course, there is a clear recommendation against these approaches. So they may add something for individual patients, but they cannot be recommended in general, and actually they are not available in most countries in Europe. What is what has better evidence is hypoglossal nerve stimulation, and you know the principle. You have a kind of pacemaker with two sensors, one in the intrathoracic muscles, the other to the hypoglossal nerve, and stimulating a part of the tongue, leading to a protrusion position of the tongue. And on the right-hand side, you see an example from our lab. Here, the stimulation is working, then it's stopped, then it's working again. And you see, when it works, there are no breathing disturbances. When we stop it, the breathing disturbances reappear. So it may work, and therefore, compared to no treatment, there's a conditional recommendation against the intervention because it's difficult to say in general that it's effective. So it should not be used as a first-line treatment. If it's compared to no treatment, we can use it in symptomatic patients if there is no sufficient treatment with PaP or with mandibular advancement devices, and it should be preserved to those patients who have been in the pilot study, in the pivotal study, which was patients with an HI below 50 and a BMI below 32. And this is critical because there are attempts to widen the spectrum more and more. And this is not evidence-based. This is only from observational studies, follow-up studies. So we recommend to stick with inclusion criteria of the pivotal study. The problem is not only availability, but also selection of the patients. And therefore, you have responders and non-responders. And therefore, we cannot give a clear recommendation, a clear general recommendation. And you know that we have to do the DICE before prescribing the devices and implanting the devices. So if you have this concentric collapse of the upper airways, then you have less success with the treatment. What about availability? And you can see regarding costs, it's not very good available over Europe. Only some countries have availability, and as you can see, in some countries it's actually different within the country. It's not the Italian colors. It's the Italian distribution of availability. What about pharmacological treatment, again, of the upper airway muscles? And we have data, not from phase 3 studies, but from phase 2 studies, showing that the combination of atomoxetine, oxybutynin, and other similar drugs improve upper airway muscles, here the genioglossus muscle activity, as compared to placebo. And this also influences breathing disturbances. So we know that these drugs are able to stabilize and improve activity of the upper airway muscles. However, they are not included in our guideline because of limited data so far. What about intervention or interaction with loop gain, so breathing regulation? We have data on carbonic anhydrase inhibitors, and they have also influenced our guideline. And you can see here, compared to placebo, there is a significant improvement in terms of breathing disturbances with carbonic anhydrase inhibitors, and therefore there's a conditional recommendation for the intervention. Other drugs, also carbonic anhydrase inhibitors, are currently under investigation. Phase 2 trial was just published and is about to be finished and is about to be published. We will see the findings in a few weeks, I guess. So what can we say in summary? We do not have the one single solution as an alternative to CPAP. But we, from my point of view, we should get rid of the idea that we have a black and white treatment. We should not only consider we have one treatment that's good and the other are bad. When we treat arterial hypertension, when we treat diabetes, we also use different drugs and different approaches. So why shouldn't we use in sleep apnea also combination treatment? And therefore, from my point of view, we should add, for example, positional treatment with carbonic anhydrase inhibitors in the future, or positional treatments with mandibular advancement devices, or other treatments. We are quite sure that we will have sufficient drugs in the near future. So we should try to find an individualized solution for our patients to give them an alternative to CPAP if they cannot accept it or want to have an easier solution. Thanks a lot for your attention.